I still can't get the pointer to work. Hello again. I'd like to thank the organizing committee. I'd also like to specifically comment on Professor Mansour's last lecture, a wonderful evolution of both the evidence to practical practice. But I have to have a quick disclaimer. I am from the Northeast in the United States. I have practiced more than 20 years, and I do use volume targeted ventilation. And as Professor Mansour tells us, only when forced to, because they failed CPAP. So for the remainder of this morning, I'd like to discuss another very specific issue in our management, both of term and preterm infants. My disclosures have not changed. I don't think there are any that are really relevant to this, except I will be calling on a great deal of evidence from the work that we've done at Cochrane Neonatal. We'll be discussing nitric oxide. Nitric oxide was selected the molecule of the year by Science magazine in 1992. That sounds very appealing. It's a long time ago, and we've learned a lot since then. What I'd like to discuss with you is the interesting use of a drug that's so successful in one population and so questionable in another. I'd like to discuss the evidence in term infants, which is strong, the evidence in preterm infants, which is hard to interpret, and discuss why clinicians feel the need to use nitric oxide in these questionable circumstances, and perhaps how we can move forward with our understanding. So first, let's just briefly discuss nitric oxide. It's responsible for the regulation of vascular tone at the cellular level. It is generated enzymatically by one of several NO synthetases from L-arginine. Nitric oxide activates guanyl cyclase by bonding to its heme component, leading to the production of cyclic GMP. And the mechanism by which cyclic GMP relaxes vascular smooth muscle is not clear, but probably involves the inhibition and activation-induced elevation of cytosolic calcium concentrations. So we see there is a strong effect of nitric oxide on smooth muscle relaxation. When we think about the entities that we are treating in the newborn related to the smooth muscle, we think of persistent pulmonary hypertension, an important cause of respiratory failure, particularly in late preterm and term infants. It's associated with hyaline membrane disease, or RDS, particularly so with meconium aspiration infection and congenital diaphragmatic hernia, a rather heterogeneous set of disorders. Conventional therapy in the 1990s, at least, was fairly crude. It involved paralysis, sedation, induction of alkalosis, hyperventilation, and use of sodium bicarbonate. None of these therapies has been proven to reduce mortality or the need for extracorporeal membrane oxygenation. And no clinically evaluated selective pulmonary vasodilator, other than INO, has been free of systemic side effects. So there's a strong rationale for using INO from animal models. There are many that are reported, all of which have an impact on pulmonary hypertension and pulmonary blood flow. In a Cochrane review of nitric oxide for respiratory failure in infants born at or near term, we see the promise of nitric oxide. The objective of the review was to determine whether or not inhaled nitric oxide improved oxygenation, reduced death, or reduced the requirement for ECMO and improved long-term developmental sequelae. The review only includes randomized controlled trials and looks at newborn infants with hypoxemia due to either lung disease, pulmonary hypertension with right to left shunting, or both. And for this review, we're only discussing late preterm infants and term infants. And they separated congenital diaphragmatic hernia patients from the other patients, as this is a particularly problematic population. In the intervention group, nitric oxide was administered either in a masked or unmasked fashion. The control group received no nitric oxide initially and received standard care. Now, this is a long list of the studies that were included. And I bring it up in part because, one, they're fairly heterogeneous. If you look here at the INO doses that were used, they vary greatly. You also can see that the numbers vary from relatively small studies of 40 patients to larger studies of 248 patients. But what's important in this list is that these are the studies that did not allow the control group to have backup treatment with INO. So if the infants in the control group were doing poorly, they could not receive INO at a later time. These other studies here, fewer patients, but still a substantial proportion of the studies, also had a very heterogeneous amount of treatment from 20 to 80 parts per million of INO. But importantly, in these studies, they allowed for backup treatment with INO, so rescue treatment. Why do I bring that up? When a substantial number of the studies do allow for rescue treatment, so-called, you both have less of an effect of the drug that is demonstrated in the trials, but you also have less of an ability to judge adverse events and side effects. And so we have to keep that in mind. And for the review, the authors separated these studies so we can examine that point. So here, if we look at the effect on death before hospital discharge, both of the studies that allowed backup on top here and the studies that did not, we see that there is one very, very broad estimate. So there's a lack of precision, and we don't see an effect on death alone when we look at the studies that either used INO only in the treatment group or allowed for crossover. But here's where we start to see meaningful effects. Regarding the use of extracorporeal membrane oxygenation, we see a large decrease in the use of ECMO. We see this particularly in the studies that did not allow for rescue therapy. Here we see a reduction of 40% in the use of ECMO, and in the few studies that did allow for crossover therapy, we see that there is no effect. When we combine the outcome of death or the requirement of ECMO, we see that there is a persistent effect in the studies that did not allow crossover treatment. Here, we see a 34% decrease in the risk of death or requirement of ECMO in the studies that compared INO to no INO. That for risk difference is around 20%, suggesting that for every 5 infants that we treat who has pulmonary hypertension and hypoxemic respiratory failure, we see 1 new infant who does not die or does not require ECMO. That's about as strong a result as you see in clinical trials. Much less data is available regarding the developmental consequences of therapy, and in fact, there is no significant effect on long-term development that has been reported. The implications for practice seem clear. Near-term and term infants with hypoxic respiratory failure unresponsive to other therapy should be placed on INO. And the therapy is very potent, as I noted, with a number needed to benefit of 5. Starting therapy earlier does not appear to further reduce ECMO requirements or mortality. In fact, INO is so important to therapy in the late preterm and term infant that we have seen a dramatic decrease in infants registered in the Extracorporeal Life Support Organization registry. You can see here a huge decrease in the past 20 years as INO has become a routine treatment for late preterm and term infants. So let's turn our attention to the more problematic population, the preterm infants. Barrington and Feiner have also published a Cochrane review that specifically addresses this population. Preterm infants are a different issue than the term infants. They do not have hypoxemic respiratory failure solely on the basis of pulmonary hypertension, though they can have hypertension, as is shown in a variety of animal models. It's hoped that if INO therapy leads to a decrease in the need for ventilator support in these preterm infants, it might lead to a reduction in lung injury and preventing or ameliorating BPD. Nitric oxide participates in both the production and the protection from oxidative injury, again suggesting that there might be effects on BPD. When we look at various suggestions for the possible effects in the preterm lung, we see multiple plausible effects of nitric oxide on lung development in the preterm infant. This can affect the lung parenchyma, improving growth. It can affect the bronchi with increased bronchodilation, and it can improve vasculature with increased vascularization. So there are many potential mechanisms for why INO might be of great benefit to the preterm infant. There are also many case reports of the use of INO in preterm infants that have suggested positive results. However, there's always some concern as we work with the preterm infant, particularly in this case, the effect of INO on coagulation, where it has been shown to increase bleeding times in adults, and obviously we have great concern in the preterm infant regarding issues like IVH and its impact on long-term development. So for this review, the authors sought to look at the impact of inhaled nitric oxide on the risk of death or BPD, IVH, serious brain injury, and adverse long-term outcome in newborn infants at risk for or having hypoxic respiratory failure. They included randomized and quasi-randomized trials, and unlike the previous review, this review was restricted to preterm infants less than 35 weeks gestation. They compared inhaled nitric oxide to placebo or control, and they enrolled infants, they included infants in a variety of studies, which they categorized as follows. There were 10 studies that looked at infants with entry for 3 days of age based on criteria for severe hypoxic respiratory insufficiency. There were 3 studies where there was entry after 3 days based on the risk that was perceived of developing bronchopulmonary dysplasia. And there are 4 studies that simply said, well, these are very small and at-risk preterm infants. We should just routinely start them in INO to prevent BPD. 3 very different indications for inhaled nitric oxide in preterm infants, and we'll discuss them separately. Here are the trials that looked at INO in preterm infants who had severe hypoxemic respiratory insufficiency during the first 3 days of life. You can see that the numbers varied from some very small studies of 20 infants to larger studies of over 800 infants. You can see that the amount of INO used differed from 5 parts per million to as high as 40 parts per million. And so, of course, it's interesting when we combine studies with such different criteria. That said, the answer is we don't see a lot of effects of INO in this population, perhaps the population that most of us would consider the most plausible to respond. In the studies that looked at these infants, there is no effect on death before 36 weeks gestation. There is, no effect on BPD before 36 weeks postmenstrual age, with a typical risk ratio of 0.94, and the confidence interval that just creeps over the line of identity. There is a concerning increase in the risk of intraventricular hemorrhage, or at least marginal increase in the risk of intraventricular hemorrhage in these infants, with a typical risk ratio of 1.2, so a 20% increase in risk, which may be nominal or as high as a 50% increase in risk. Then we take a look at a rather unusual group of studies that is focused on treating infants who might have evolving BPD. And here, of course, we have both the Ballard study of 582 infants and the new nitric oxide study of 452 infants. So we have few studies, but they are relatively large in size. Here, we don't see a difference in death before 36 weeks gestation, either in the new NO study or the Subidar study. Also, we don't see a major difference on the risk of death or BPD, with perhaps a slight decrease noted in the infants who received inhaled INO. And lastly, we look at the 4 studies that involved infants who were thought to be at high risk of developing BPD simply because they were on respiratory support early on in the first week of life. Perhaps some of the largest studies are included here. Kinsella's study of close to 800 infants and the UNO study of 800 infants. Here, when we look at the effect of death before 36 weeks gestation, in fact, we see a concerning trend towards increased mortality in this group of infants. When we look at the combined outcome of death or BPD, there is a marginal decrease that is not statistically significant. So the implications for practice based on the Cochrane reviews say that in very sick preterm infants who meet the criteria for poor oxygenation, rescue therapy with INO does not significantly improve survival or survival without BPD or brain injury, even though oxygenation may improve in the short term. There is some evidence of an increased risk of severe intracranial hemorrhage. In these findings, the authors recommended not using INO routinely in preterm infants. In contrast, the early routine use of INO in ventilated infants who are not severely ill, but nevertheless are at risk of serious brain injury holds some promise, with single large studies showing a trend towards improved developmental outcomes. So when we try to support these results with a more sophisticated analysis, this is an individual patient analysis done by Lisa Askey. So instead of looking at the study level, she gathered data on all the individual patients enrolled in these trials, because there's always a question about whether or not the dosage of INO initially mattered or how much gestational age matters. And although this is a very busy slide, basically, she did not, through the individual patient data meta-analysis, demonstrate any improvement in any subgroup on death or chronic lung disease with inhaled nitric oxide treatment. At least in the US, this led to a fairly negative statement from the NIH. They say, taken as a whole, the available evidence does not support use of INO in early routine, early rescue, or later rescue regimens in the care of preterm infants less than 34 weeks. They do open up the discussion, though, to a group that many investigators have expressed concern about. And they note that in rare clinical situations, including pulmonary hypotension or pulmonary hypoplasia, which have not been adequately studied, there may be some benefit. But that's just a big maybe. There is no evidence to support such. In such situations, they suggest that caregivers communicate with families regarding the current evidence and the risks and benefits. Similarly, negative reports have come from the AAP, which do not recommend the use of inhaled nitric oxide in preterm infants. So given the evidence we just covered, and given those recommendations, here's the surprise. There is a great deal of use, at least in the United States, of off-label inhaled nitric oxide. So basically, in the pediatrics medical group, between 2009 and 2013, they looked at their rate of inhaled nitric oxide utilization in preterm infants, 23 to 29 weeks gestation. And a few things they noted in this review. One, almost half of all the use of INO in their medical system involved preterm infants. So unlike the reviews which say this is great in term infants and questionable in preterm infants, half of the time that they're using INO, it's in the preterm population. And they've seen a shocking threefold growth in particular in babies 23 to 29 weeks gestation. In Vermont Oxford Network, we see a similar persistent use of INO. And this is an interesting slide because it speaks to the variability of centers' choices. The red line is the mean. And you can see that approximately 5% of VLBW infants are treated with INO. But here are our quartiles. The blue quartile is the third quartile, which means that 25% are using 5 to 6% or more infants. But in 25% of the hospital, the bottom green line says they never use it. Okay, and so clearly it's not just 5% of VLBW infants get it. The answer is some hospitals never use it and some hospitals use it a lot. So Feiner, who's the author of the 2 Cochrane reviews, wrote an editorial about this disconnect of evidence and practice. He brings up 3 possibilities about why there's this disconnect. He says, first, and least likely, there's a lack of awareness of the evidence. He says, I don't think that's the case. Perhaps because he wrote the reviews, he hopes people's read them. Second, and more likely, is that people feel the evidence is not generalizable to a particular situation. And third, and most likely, is that despite the evidence, we have an instinct to normalize physiology when faced with a hypoxic ventilated baby. We have INO in the unit. It's available for term infants. And like a little boy with a hammer, a little 2-year-old, suddenly everything in the unit needs hammering. And so we wheel the machine next to the preterm infant and we turn it on. And perhaps we see some increase in oxygenation and we believe we brought some good. Now, because of this disconnect in the community, it's interesting that many of the people most involved in the research published alternative recommendations. Now, Steve Abman is the senior author on this, and I count Steve as one of my very best friends. He and I have bicycled through Vietnam together, but we never discuss nitric oxide because we completely disagree on this subject. And he and these other folks, as I said, many of them who are the investigators, and perhaps you could argue the most knowledgeable about nitric oxide, came up with an alternative set of recommendations, which I don't endorse, but I think is sort of the rationale that drives practice. So this is a long-winded slide, but to say it briefly, the trials in preterm infants to prevent BPD did not show great effects. And as they note in their commentary, that's probably why the NIH and the American Academy wrote statements that were not supportive. But then they argue that, in fact, the populations that we think we're treating are those unique populations that were alluded to in the recommendations, infants with severe pulmonary hypertension. And none of the trials that I discussed really screened carefully for that population. And so they believe that there are individual cases that show it will work in this population, and that this perhaps is the population we should consider treatment in. Now, they discuss many controversies, and they do note that the use of INO in preterm infants has been left to clinicians' discretion. But it's hard to imagine that so many at some centers are deciding to use it in what I would argue is an indiscreet way. The authors of the recommendations of this secondary set of recommendations say that it would probably be impossible to conduct a clinical trial in this situation based on the strength of physicians and caregivers' feelings about this and the difficulty in collecting the numbers. And I do not agree. But we'll go into that in a second. Their recommendations then are that we should not use INO for the prevention of BPD, that INO can be beneficial in preterm infants with severe hypoxemic failure due primarily to PPHN. This is an unproved point. And that INO is preferred over pulmonary vasodilators in preterm infants based on the randomized trials of BPD prevention in terms of safety, and that they feel placebo controls are not reasonable. They conclude that there is extensive data on safety and that we should consider using it in this population. Their point is not held up when we look at the real world data outside of randomized controlled trials of who people have decided they'll go ahead and treat with INO. Here's some work from Carey and colleagues that took a look at the pediatrics medical group clinical data, similar to what I showed you before. And through a sequential risk approach, each patient who received INO during the first 7 days of life was matched using propensity scoring to patients who had not received INO at a chronological age before the case patient's INO initiation. Among 37,909 newborns, they identified 993 who received INO, and the 2 matched cohorts were compared. They did not observe any significant association between INO exposure and mortality. So even in terms of whatever clinical discretion is going on, the use of INO in real world did not make any difference in survivor. So I did write an editorial on this for pediatrics, and I disagreed with the secondary set of recommendations regarding trials. I noted, as we've just discussed, that there's little evidence from the randomized controlled trials and a fairly strong statement from the NIH. There is this belief that it may work in a select population, particularly PPHN and pulmonary hypoplasia. But here's where I disagree strongly. I think trials are still possible. There are trial designs which are adaptive in nature. And if you think back, the first trials of extracorporeal membrane oxygenation were done in just a circumstance. The trial design they used was something called play the winner. And this is a successful approach when you think you might have a life-saving therapy in hand that you don't want to treat a lot of, or at least withhold treatment from a lot of infants who might benefit. The trial design works as follows. Originally, you have your normal randomization. Then you pull from the thing and it says, oh, I should treat, in the case of the ECMO trials, with ECMO, in the case of my proposed trial, with INO. If the baby has a positive outcome, in this case survives, you then shift the randomization and you add another ball to that little basket there that says, oh, randomize that child to the intervention, INO. If lots of infants continue to do well, you follow them and you say, okay, it only took X number of infants before we proved in this situation that INO is in fact life-saving. I would bet a fair amount that unlike ECMO, if we did this type of adaptive trial, we would at least answer the first most relevant question of whether or not INO treatment is life-saving in preterm infants. So neonatologists have been voting with their feet, and they've been using INO despite little clinical benefit. I think that it is time for such a clinical trial to address these issues in the newborn. So I'll end there. I think it's clear. INO for term infants is one of the major breakthroughs in care in the past decades. It has decreased the use of more invasive and costly therapies like ECMO, but I think it's completely unclear in the preterm infant. And if anything, should be used with caution in the context of talking to families, further evaluation of the infant regarding pulmonary hypertension, and the possibility of newer adaptive trials. So I'll end there. Thank you.
Thank you, Dr. Rogers. Thank you. Disappointing evidence. I ask our eminent speakers for the discussion and question. And I'm sure that the floor, we have a lot of questions now. If nobody will start, I will start myself. Simply. Anybody has any question from the floor? I will start my question. Mansoor, I know we are very familiar now with the BG, but still we have a lot of air leak syndrome, pneumothorax. What is your explanation? If you are controlling the volume and there is no volume trauma, still there is many cases end up to have a very bad air leak. So what's the explanation for that?
I think I'm not. Of course, when we look at any morbidity in NICUs, we shouldn't link it to one thing. But definitely there is bundle in the care can prevent anything. And for example, we talk about air leak or pneumothorax. I think very important to look at the tidal volume, how much pressure the baby is getting, try not to intubate and put them, in very invasive ventilation. And maybe Profani can, or Professor Saul can comment. Sometimes we put them in CPAP, and sometimes the CPAP level 6 or 7, and then the baby is confidence improve, and with the same that beat can lead to pneumothorax. And that the data earlier with the CPAP was utilized with higher rate of pneumothorax on in infants who receive CPAP. But I think it's to do with us. We have to adjust any respiratory device used according to the patient condition, according to the blood gas, according to improvement and change in pathophysiology. What I see sometimes, we put the baby in a ventilator or any device, but then we forget. And then at nights, for example, the baby, let's say, I've seen babies who have CPAP of 6. And then, people do not, babies in room air, and, maybe that CPAP of 6 will over distend the lung. And I've seen cases in my unit where the CPAP left and could have been adjusted lower. And that's also for the ventilation. And then you find the baby had pneumothorax. So I think, I suggest that it's a bundle of care. Suction, for example, we have sometimes nurses do suction in a very aggressive way, and the baby will fight. You know what I mean? So I think it's to do with many things, not one single point to prevent. But definitely, volume trauma is a major, cause of pneumothorax, and I think we have to always be looking at that. And I think if you ventilate babies, look at the tidal volume. Look at this something called C20 over C. When we ventilate babies, we look at the compliance curve. And we know that if the C20 over C, C20 means the compliance at the last 20% of pressure volume loop. If that C20 over C is less than 0.8 or less than 1, indicate you are over distending the lung. You can look at the pressure volume curve. If the curve is peaking, that means you are over distending the lung. So I think it's not one thing, it's many things. And I'm sure our senior neonatologists know there is no single product to prevent any disease, but I think it's multiple things. But there is major things we could do. And I think quality improvement projects. If you see like rate of pneumothorax high in your unit, look at this. Look at the pressure, look at the volume, look at the suction, look at the way we change and modify our respiratory management accordingly. And I'm sure you'll find bits and pieces of things. You put it together, you come with a quality improvement project, and then you find your rate will go down because you attach, I studied it in a very scientific way or very practical way. Thank you.
Yes, Sergeant.
I have one comment. It's much like what we discussed with CPAP. There is no respiratory intervention. There are respiratory strategies. They involve training of the team. They involve follow-up. They involve a cycle of seeing how the baby's doing and adjustment. That has to be a great deal of training. And although I fully endorse volume ventilation, the unit needs to be trained in it, trained in weaning the infant. So many times on rounds, we're so self-satisfied that the baby looks good today. Well, those settings will harm the baby tomorrow. And so it's a constant iterative process. I couldn't agree more.
Okay, thank you. So any further question? Dr. Jubara or Mansur? Jubara will hear you.
Thank you very much for all the speaker. My question for Dr. Mansour, what about high frequency with volume?
You take it from my tongue. It was my second question. Yes, Mansour. High frequency and VG.
And I can tell you that, we in our unit, we introduced volume targeted high frequency since 2015. And I think we built our knowledge and experience. I think Profani had mentioned very clear statement. You have to have a learning curve for anything you do. And sometimes you start something, but you don't have enough training, everybody in the same page. You know what's the indication, how you wean down, I think you'll have problems. And definitely, this learning curve it's a natural thing, but we can minimize it to reduce by enough training. I tell you, sometimes we bring the device in the unit and we just start it, but then you find people do not understand how to use it, and then you find problem, and then we think it's bad. But to answer, I'll have a lecture, I think, in November in Riyadh about volume targeted. As the time, I think it's still evolving concept. I know there is data suggested that it could be helpful. In our unit, when we use high frequency, we use volume target filtration, and we try to use a target volume between 1.4 to 1.89, and then with high frequency volume targeted, the frequency will conventionally improve ventilation. We know that when we fix the tidal volume and high frequency with volume to guarantee the frequency, classically in a high frequency, you increase the frequency, you deteriorate your CO2, so you have more accumulation. However, if you do volume targeted, you can increase frequency to achieve a higher ventilation or better ventilation with the smallest tidal volume. I tell you, we use it. We found it a very more consistent CO2. We found it. We are now collecting the case series of our unit where we use it. I'm not sure it's yet the standard practice, but I think, very important concept, the tool and the carpenter. When you apply something, you have to know how to use it. Because sometimes, if you have many consultants in the department, attendants, and everybody has his own way, the medical staff in our unit, nursing staff will be confused. Dr. Mansour likes this, Dr. Dubara doesn't like this, Dr. X. I think we have to have, I'm not saying we should be carbon copy of each other, but I think the common practice in units should be homogeneous.
Yes.
Because, other assistants come and they, what Dr. Mansour like is this, and they what Dr. Dubara, what Dr. Hindi, I'm talking about my unit. But then we don't have homogeneous approach. But so we should agree as attending in any unit about a common practice, and then we have variation. But to have everybody doing his way, people will have less training, and they will have not a good data to suggest whether you are okay or not okay.
Professor Saad?
One question already answered by Dr. Mansour. Just have a comment regarding the nitric oxide and the molecule of the year in past meeting in 1992. At that time, I was fellow one, more than 200 papers, and abstract was presented.
So yes.
Then after that became a fashion. We as a neonatologist, we thought that nitric oxide is going to solve all our problems as a neonatologist. And I remember at that time, even when we started nitric oxide, the years after, we opened the windows in the NICU because there was a concern that NO2, the toxic, may affect the nurses and the doctors. And remember that a small fellow from Jeddah in -14 Winnipeg, and the window is open from time to time. Anyway, later on, it has been found that it's not significant to open. So opening the window during nitric oxide is open. Now, as we saw today, become more realistic. And yes, nitric oxide is still important, but some other issues need to be addressed. And as you said correctly, Bob, sometimes you're stuck with very sick newborn babies, and you don't lose the baby, and you don't have any alternative. Subconscious, you may start trying nitric oxide. I know there is no clear evidence in procurement, as we saw today. The problem is in the court. For example, if a child has IVH grade 3 or 4, of course, it's multifactorial. And one of them could be nitric oxide.
You will not go to the court.
And
believe me.
And what I'm going to say, bro.
You will not go to court.
Against me when I use it for this.
Right. Another question?
And
Yes.
if
Dr. Majdi,
that side with that family, I might use it too.
give mic to Dr. Majdi, please.
Thank you.
Thank you, Dr. Mansour. Thank you, Professor Georges. Now I would like to ask Professor Roger about use of nitric oxide in extreme pressure. We are using it. Nobody can say that we will not use. We are using it, and I think we are going to use it more. The problem is, as Dr. Sadi has said, sometimes you have a very sick newborn, very sick, extreme preterm. Even sometimes he developed chronic lung disease and started the pulmonary pressure to become more. Do we have now today a strict message not to use it, or we can use our, for example, if we are our back to the wall, we need,
Yes.
we have to use it.
Yes, Roger. Use or not use?
So
No.
do I
I
look
know, no.
heartless?
No,
No. I am in the same position. When someone from a hospital 150 miles from my hospital sends me a sick preterm infant in hypoxic respiratory failure, having told the parents there might be a life-saving drug at the medical center. I do not lecture them on the evidence, okay? I start nitric oxide, but I'm a skeptic. I will not settle for the "it can't be studied anymore" comments. There is currently no evidence. We need how to learn to use it better if we're going to use it at all. These infants need echoes. They need to be characterized. And we at least need either a registry or clinical trials involved in that. But in your shoes, I do the same thing. It's not about how smart I think I am. It's about a patient's life. And I'm willing to say it probably does little harm, and I'm going to give it some benefit, but I really would love to have more knowledge. I added that yellow caution there because I feel the same way, and I feel hypocritical to say don't use it. What I am saying is the evidence is poor. We have it available, and we have a community that thinks there may be some benefit hidden that the trials has not resolved. We need more study.
Okay. Any further comment? I will make it more difficult for you. When we have a scenario, a preterm baby receives surfactant, improve, suddenly start to increase his oxygen requirement, you thought maybe BDA. Then you called the echocardiogram, they came and said, yes, the BDA is open, but there is some degree of BPHN. Which one you will treat? You will treat the BDA with indomitacine, or you will treat the BPHN with a nitric oxide? Very difficult situation.
So I'm not sure I've ever been confronted with that.
We did that. We face a lot of cases where we have the BDA.
Certainly, patent ductus post-surfactant treatment is common, right? We know that it decreases lung compliance, it increases flow. How much treatment of that is needed? That's topic for a whole day of this conference, right? I've not been confronted with this, so I don't know. I would probably attempt treatment of the ductus first, but I'd be curious what others would do. I don't have.
Well, I went through the same thing when my colleagues said, no, we'll treat the duct. I said the baby will die because it's the only pump out for the blood. Yes, honey. Treat or not treat? Ductal deviation. Allahu Alam.
So I'm so concerned with the PDA, the direction of the flow. So if there is a right,
Bidirectional.
if the right to lift shunt
Bidirectional.
or bidirectional, I wouldn't treat the duct because really it is needed to as a pop-off valve for the pulmonary hypertension. But if it is left to right shunt, I will treat.
Well, the echo finding was a large duct with a bidirectional shunt. Which one is more? I don't know. Right to left is more than left to right, or
But
left to
the
right.
fact there is bidirectional, it means there are still some right to lift. There shouldn't be any right to lift if you really are having a normal physiology. So having bidirectional, I will add it to the right to lift.
Okay.
maybe a comment here also. Now there are
Tafadhal,
more
Abu.
evidence that treating BDA may not affect the final outcome. In a case like this, maybe I personally tend to wait. I will not close the lectures. But however, there is no clear against
Answer.
or with.
Other scenario, question, comments? Still, we have another 15 minutes. Period with question. If not, I'll take over. You allow me? Okay. So the second question, what is the cardiac contraindication to use the nitric oxide? So sometimes you don't have the echo. The echocardiogram is not there. The cardiologist will not come to do for you the echo to confirm this is BPHN. You assume it is BPHN. You start nitric oxide, the baby deteriorate further. You thought maybe I'm dealing with some left to right or left outflow obstruction like coarctation. When to stop the nitric oxide? When to take now is enough? Maybe we need to have further cardiac evaluation.
So if I'm hearing the question correctly, it's a preterm infant who does have echo evidence of high pulmonary. I too would consider inhaled nitric oxide. I am not worried about side effects.
No, this is a term baby.
Oh, term baby.
Mhm.
Oh,
Where you have a cardiac case, maybe a cardiac case in the up to be deteriorating after you start him in nitric oxide.
I don't have a good answer here.
You don't experience that. Anybody experience a left outflow obstruction, coarctation, you start nitric oxide, baby almost dying. Yes, honey.
Generally, there are some diseases that you really would like to keep the baby, cardiac disease, that you like to keep the baby on the hypoxic side.
Yeah.
And actually at CHOP in Philadelphia, they used to give a CO2 OXIDE to cause pulmonary vasoconstriction. So for example, hypoplastic left heart, he will have a problem, total anomalous.
Yeah.
He will have he's not gonna die from nitric oxide, but you may see a worse problem from pulmonary edema.
What about nitric oxide in BPD? Cases of bronchopulmonary dysplasia. Does it improve the oxygenation? Does it improve the outcome?
So again, the trials tell us little benefit in evolving BPD. But I think your question more relates to the infant with BPD who seems to have high pulmonary vascular resistance. No formal trials have been done. People have suggested INO, people have suggested sildenafil as a possible treatment of those circumstances, but there's no clear evidence about benefit.
Yes, we'll call you for last comment from Dr. Hani and then Jubara.
Yeah, I will put my voice with Dr. Saul that the problem with, that's the one I have a highest problem. I don't have a problem when you have a baby with 100% oxygen on the oscillator and he's dying and you're giving him a trial of nitric oxide, premature baby or extremely low birth weight, because that trial will show one way or the other within a couple of days.
Yeah.
But the problem when you get stuck with a chronic lung disease and you start nitric, when are you going to stop it? He's going to stay forever. So I really will highly caution not to go there, because, or before you go there, are you planning to keep him for 2 months on nitric? Or are you planning to just give it a trial, and then if he resolves or improve, then you start sildenafil. We start to use it more now. Start to use sildenafil and take off the nitric, something like that.
Jubara.
What about term baby who had a chronic lung disease for underlying lung disease? I mean, for baby, for example, post diaphragmatic hernia repair, and they are, 1 month and they have pulmonary hypertension. Is there any rule for the nitric oxide later for a full-term babies with primary lung disease?
It's hard for me to say, as you know, there is no trial data for that. And I'd like to just stay with Professor Ali. It's hard to know what my stopping point would be. I think if there's research to be done, it should be done in other vasodilators, such as sildenafil, where you have some promise of sending the child to home or some home care plan. That said, I don't want to be seen as the heartless person. That infant sick on the ventilator for a trial for a day or two to see if the child's responsive even to a vasodilator like that, where I might then say, okay, now let's try to wean to sildenafil. I might try, but these are all one-off cases. These all have us scratching our heads, right? And doing whatever we can for the family with very little evidence.
Okay.
So we give a trial for nitric oxide for those babies. If they respond, we'll continue. If not, we will stop it. But the problem, if they respond to that,
Right.
for how long we keep them? Like, if you stop it, they will be hypoxic
Did you
again.
try to substitute sildenafil?
Yes, with all.
Heartbreaking.
So this is really
That's
very
what-
difficult cases in this case.
That will call for my lecture tomorrow. All this is advocating for my lecture tomorrow, Sidna Peel in Saudi Arabia. I think we need to conclude here, and we thanks everybody for listening. Thanks for our eminent speakers, and we'll see you maybe by 1 o'clock in the afternoon. Enjoy your break, enjoy your lunch. Thanks a lot.